My name is Verena Kreiliger. I'm the Global Hospital Physiotherapist for the ICRC Hospital Projects. I will co-presenting today with my colleague from the Rafa Field Hospital in Gaza and Dr. Levine Nahid. We will share the presentations. I will do the start and then we will hand over to her. So today we are going to talk about the very important topic of fracture management in conflict. As we have heard throughout all the other presentations already, in conflict we don't have only one problem by itself. We have a multitude of injuries often which we have to cope with as rehabilitation specialists. Just 1 minute, I have to. Yeah, sorry. So today, the aim of this webinar is that when we're working in disaster and conflict, we cannot always provide the treatment we would in contexts where there is high resources and high capacity. So in conflict and disasters, we need to focus on the best care possible, and it's not always what is the highest standard and what is recommended in the literature. We need to be prepared and we need to have training in the key areas. So preparedness of each professional, so each professional knows their role in the emergency setting, and this means mainly in the mass casualty and mass casualty response, which is often what is happening. So in conflict settings, we have a high demand and a high request for triage to optimize the health professionals' involvement. Physiotherapy participants physiotherapy participates and ensures that the hospital is a safe place for the patients and that patients can be safely discharged. I think one thing which is very important, we have people from across all contexts, and we need to, as health professionals or as rehabilitation specialists, we need to ensure that we work within the framework of our context and of our country. I mention this in specific because there is contexts like Iraq and Lebanon where physiotherapists are not allowed to apply plaster of Paris management for fractures, and that is one of the techniques we use quite frequently in conflict. So today we're going to talk about fracture and fracture management. I would like to put a disclaimer. I'm a physiotherapist. Dr. Naveen is also a physiotherapist, so we have no surgeons on the team presenting today, but the presentation has been put together with the help of surgeons, nursing, MHPSS specialists who have put their input into it. We will talk about adaptive clinical management for surgery, nursing, and medical MHPSS, as well as rehabilitation context. We will specifically look at the management of fractures with plaster of Paris, as I mentioned before. We will mention traction and external fixation, as well as complications, challenges, and important considerations. Now I would like to ask Chloe to launch a poll. I would be very interested to know if you, the participants, are actually working in active conflict zone at this point in time.
Verena, it's Chloe here. Just whilst we let the attendees respond to the poll, we've had a few requests maybe for you to just speak a little louder if you possibly can into your microphone. Thank you.
Okay. All right, while we will continue with the poll, answers are still coming in. I just want to talk a little bit about fracture management generally. So when we have fractures in conflict settings, as I said before, we want to do the best treatment possible. And we want to encourage a maximal function post-fracture recovery. This can be achieved by promoting interdisciplinary work, so it's quite important we work as a team quite closely together. And we must ensure that we have the competencies related to the management of fractures. With plaster of Paris, if that is applied by physiotherapists, that we know how to work with external fixation and with fraction. Including patient care and information is very important. So the family and the patient and the carer need to be involved in the rehabilitation. As rehabilitation professionals, we also need to ensure that we know when to seek support and when we ask the service user to come for proper follow-up. So the interdisciplinarity is a very important part of the treatment. I think I will stop the poll now. Do I stop the poll or do you stop the poll, Chloe?
I've stopped that. I'm sharing the results. Hopefully you should be able to see it, attendees.
Yes. Okay, so it's really interesting. I can maybe just quickly speak to that. We have about 34% of the participants who are actually working in active conflict zone at the moment. And we have 66% of the participants who are interested in the topic. And I presume this is because you're interested to work in conflict zones or because you want to get ready and prepared. So, thank you very much for that participation. In conflict and in disaster areas, we have fracture is the highest percentage of the injury we see in these situations. Typically, the majority of the fractures will be in the lower limbs, so in the legs, and some of them will be in the upper limbs, but it is plus or minus 80% of cases in the lower limb. One very important distinction between normal fracture management and fracture management in disaster and emergencies or in conflict zones is that we very seldom have closed fractures. As I said at the beginning, the majority of fractures are one of the injuries, and we have often associated injuries such as we have heard before, like TBI are very common, burns are very common, so we often have very complex soft tissues injuries, which we have to negotiate at the same time as we have to try to ensure we get the best alignment for the limb and limb fracture. The fractures are mostly comminuted, meaning they're complex fractures. You've seen the picture in the second slide, where there is lots of different bone fragmentations, and it's very seldom that we have simple fractures. This is because of the trauma and the way the fracture happened. So, polytrauma and multiple fractures are more common than simple fractures. Also, very frequent are involvement of nerves or vascular involvement as well, which can have a big impact on the long-term outcome, as well as soft tissue, as I just mentioned before. We need to consider that open wounds with fractures are very dirty and very contaminated, and therefore at hugely high risk of infection. And the importance here is that while fracture is very important and a very important long-term potential, if it's badly managed, long-term problem, A patient will not die necessarily of a fracture if there is no nerve or vascular injury. So if we think about the first management of a patient arriving in a hospital with a fracture, the fracture immobilization is secondary to the wound and also secondary to ensuring that the patient is not bleeding to death. Once the soft tissue and the additional problems are dealt with, we know that for successful bone healing, an early weight bearing is essential. So that's where physiotherapy comes in as well. I will now, the adaptive clinical management for surgery in low resource settings has the aim to bring the best care possible in the given context. And it's not necessarily the best care described in academic literature. Tractions versus internal fixation. The fracture management must respect the local standards and procedures. So I refer here as a comparison, the Lebanese example where physiotherapy is not allowed to apply plaster of Paris versus the Yemen or the Gaza context where it's the physiotherapist who does the POP management. Very crucial from the surgical side, in particular in open fractures and in crush injuries, is to assure that there is very good debridement done before providing any definite fracture management. So as I said before, the more important part, or the very important and crucially important initial part of the management of the patient is to ensure that the wound is really well debrided and there is no risk of infection before we actually deal with the fracture. I will now hand over to Naveen. Naveen, please.
Yes, thank you, Verena. Good morning.